So Dr. Falls is an associate professor at UTMB Department of Psychiatry and Behavioral Sciences. Dr. Falls has board certifications in general and a child and adult psychiatry with 22 years of postgraduate experience treating the gamut of psychiatric disorders. Her interests include serving the underserved via telepsychiatry and addressing the mental health care clinician shortage via CPAN, the Child Psychiatry Access Network, and collaborative care work with family medicine. She also enjoys teaching students and residents. And as I've mentioned just previously, this is the first time that Dr. Falls has presented for us here with CPAN and, excuse me, the partnership that we have with UTMB. So Dr. Falls,
quite a bit, but that's all right.
When you're ready, you can go ahead and share your screen. And I'm going to put myself on mute. And yep, we see you're right, the correct screen.
I'm wanting to have it to where it's just one and not all of these kind of at the bottom. What are you guys seeing right now?
We see just your primary screen that says managing complex ADHD in pediatric primary care. I think you are good to go.
Okay, good deal. All right, good afternoon, everyone. I have a lot to cover, so I'm just going to dive right in and praying that I can actually get through it all. So, disclosures, I don't have any actual or potential conflicts of interest in relation to this presentation. And I will be discussing some non-FDA approved off-label medications, which are listed here. And so we'll keep going here. The objectives of this, when I was creating this talk, I tried to think about what kind of some of the most calls that I got, or what type of calls did I get from CPAN, or pediatricians, and tried to create this around those kinds of questions. So my objectives for you guys is to basically hope that you can develop a systematic approach to evaluating ADHD. And knowing that if you can do that, then ultimately, hopefully that will assist you in treating complex ADHD. And in some cases, prevent maybe you from getting to having to address things that are complicated. Hopefully you can just take away a couple of nuggets from this. It's going to be a lot of information, but if you can just take away maybe 2 comorbid disorders and how that can impact initial treatment, or how you can address that. Maybe 2 potential side effects of first-line ADHD treatments and how to address that. Okay, so this was from Bergman, who was evaluating some evidence-based guidelines and critical pathways for quality improvement in pediatrics. And so I liked this quote, which is, the primary goal of guidelines is to standardize care. So basically, again, it just summarized what I would like to see is that hopefully we can just give you a way to try to look at, is this doing this? Are y'all seeing notes on this or no?
No, ma'am, we are not.
Okay, sorry, I hadn't had it do this before. Okay, so comorbid conditions. When you're looking at it, it's going to seem like an odd place to kind of start. On this talk on treating ADHD. So before you start treating, you obviously have to look at diagnosing and then looking at differential diagnoses. So comorbid conditions, ODD, anxiety disorder, and it can look like just we've thrown everything in the kitchen sink in for a comorbid disorder. But this really is pretty much the case with ADHD. And it's important to recognize that, because sometimes parents will say, even once you get someone treated, well, the medication isn't working. And so we want you to ask, okay, tell me, what is it not addressing? Because sometimes the knee-jerk reaction is to go ahead and increase the medication. Parents will sometimes say, oh, well, they won't do anything I tell them to do still. And then I'll say, well, how are they doing with respect to school? And they'll say, oh, well, they've gotten much better in school. They're doing their work, et cetera. So it's important to kind of understand these comorbid disorders so that you can explain to parents what the medication will and won't treat, and even so that you know what else might need to be treated. For instance, we often don't even diagnose ODD until we have sufficiently treated ADHD. Also, remember to put in a referral to psychiatrists you suspect that there's complicated ADHD. As you all know, there's a wait list. All right, and differential diagnoses going to kind of look like that last list. You know, is it ODD? I don't have that necessarily on the slide, but that is something that sometimes we're looking at. But depression, anxiety. In depression, basically those kids are going to have a lot more neurovegetative symptoms and not just concentration issues. Anxiety, this is hugely comorbid. And for that, you're looking at one of the things we see a lot is social anxiety. So those kids will tell you that they can't focus, but it's because they're thinking in their head that they're going to say or do something embarrassing. The teacher's going to call on them. Other people are critiquing them. So that's why they have concentration difficulties. Learning disabilities, of course, if you know, be looking for they're having a problem in a particular subject, math, but they're doing great in everything else, or reading. Intellectual disabilities, autism, psychotic disorders. And psychotic disorders, sometimes we forget about that. It's not super common, but it can happen more frequently than I think sometimes, especially primary care providers are recognizing. And they will tell you that the voices that they're hearing are distracting them in class. Okay. Let's also not forget about abuse, substance use disorders, kids, especially if they have comorbid anxiety, the teenagers will do marijuana and they'll say, well, it helps me not care about, you know, stuff that makes me anxious anymore. And what they don't realize is that it helps them not care about everything, including their schoolwork and other stuff. So you have to keep that in mind, as well as normal to high normal inattention and high activity. Now, this particular differential diagnosis, I kind of wanted to spend a little bit more time on because there's more literature about ADHD and a comorbid irritability. And sometimes people will then kind of start assuming that it's bipolar. But not only that, how do you tell the difference between these two? Because if you treat ADHD and not recognize even the possibility of bipolar, then you could potentially send someone into mania. Now, even if you see little red flags, not enough for you to say bipolar, at least if you're recognizing that the flags are there, I think it can guide some of your treatment, or at least cause you to, you know, tell the parents, hey, look, you want to be on the lookout for this. So the reason why sometimes even for psychiatrists it's very hard to tell the difference between these two is because they have all of these overlapping symptoms. So insomnia. Now for ADHD, most parents will tell you those kids, if they can just hold them down long enough, I mean, they're bouncing all over the place, but they can hold them down long enough, they conk out. Nobody wants to sleep with them because they're all over the bed and they get tangled up in the covers, but they sleep through the night. Whereas bipolar kids are truly having a decreased need for sleep. They stay up all day, all night, sleep 3 or 4 hours a night. Those parents tell me and beg me, like, please, you have to, because you hate me, or, you know, something's going to have to give. Nobody will babysit them. They're like trying to cook at nighttime, be in the microwave, doing all sorts of things. Hyperactivity, again, that's something in both, and it's hard to tell the difference between ADHD and bipolar hyperactivity. Talkativeness. ADHD is kind of a chatty kind of talkativeness, but you can redirect them. You can give them something to do that'll at least keep them occupied for a little bit. It's going to be truly like adult bipolar, where it's a pressured need to speak. A pressured need to speak when you're talking about bipolar in kids. And you can't interrupt them. And then, of course, the distractibility, irritability, all can kind of look alike. So this is just to say, really kind of keep this in mind when you're looking at diagnoses. Guys are, you know, this is definitely more in your wheelhouse, but it's non-psychiatric that you need to think about: absence of petit mal seizures, thyroid disorders, hearing and visual impairment, OSA or obstructive sleep apnea. This is definitely key, especially if kids have tonsil problems, enlarged tonsils, or they're overweight. But I do remember when I was still practicing in Waco, where they were talking, oh, you know, maybe a lot of kids are being misdiagnosed. They don't really have ADHD. It's just OSA. And so they had this kid on who the parents said, oh, he has enlarged tonsils. And so they removed his tonsils and he's been fine ever since. He doesn't have any ADHD. as the child was jumping all over the sofas, hopping over the sofas, still kind of probably had some ADHD. So I think a lot of times it's not going to completely take that away, but it is something to consider. Head injuries, and you'll be looking at typically more of an inattentive type of appearance for that, other encephalopathies. So unfortunately, a couple of my slides are out of order here, but rating scales. Basically, I know I'm speaking to the choir. I know that you guys know this, but I think it's important to remind you because I think oftentimes I do some work, collaborative care work with family medicine residents. And so even though they know it, your volume is so high and you're getting kind of behind. And so I think it's easier to then start floating to letting such tools be kind of diagnostic for you. And so you just want to remember that it is a tool. If, however, the ratings fall within the upper 5th% for a child's age and gender, there's a reason to be, concerned. Make sure that the rating scales are free. And the only one that I know of that's really free right now is the Vanderbilt scale. We do like that one too because it covers not just ADHD symptoms, but it also covers, a little bit touches on anxiety, depression, other behavioral problems as well. Okay. Once you're kind of looking at treatment, what do you want to go to? And of course, usually when parents come in, they're going to tell you they want a medication. You're probably going to think about medication because it's quickest and it's really what you can do. I put this slide first because I don't want you to forget about behavioral therapy. Oftentimes when I'm getting CPAN calls, I'm asking them, is this child in therapy? Because I'm almost always hearing something that says that they need to be in therapy. And so they'll say, oh, the parent is refusing, or, they say they're going to do it, but they haven't gotten around to it. We'll talk about some more studies in here that really drives this message home that behavioral therapy really needs to be happening and, early on. Parent or teacher administrated behavioral therapy is sufficient, evidence-based, and you want it, especially in preschoolers, that's going to be first line recommendation for them. And the focus is often on parent training. Then this is where the comorbid disorders again come into play. You want to look at other therapies. So if you're seeing some depression, anxiety, you want to look at cognitive, behavioral therapy, referral, family therapy. Keep in mind that ADHD is a very highly heritable disorder, about 75 to 76%. And so you're dealing with families, parents potentially, who also have ADHD. Sometimes they don't even know it. It's been undiagnosed and treated. And so it really helps them to get the whole family organized and to get them treated to be able to better help their child. Diagnostic, and this is where I said slides were somewhat out of order here. The diagnostic and pre-medication workup. Basically, parents will still ask us, hey, is test that says that my child has ADHD. We really don't have any test that say that your child has ADHD. It's still predominantly going to be a diagnosis of symptoms, utilizing, in this case, DSM-5-TR. However, there's like continuous performance test, is for age 8 and older, and I think they've had some updated versions of it, but it's kind of expensive. A lot of times insurance doesn't cover it, and you can still find out what you need to know still with a good history. It can be helpful sometimes if you're medicating and then wanting to see a baseline and how well medication is, kind of more objectively comparing the results pre and post medication or post medication changes. Sometimes you may psychological testing. Again, sometimes it's not covered, and then it's hard to get the school to do it. It's not that it's not an issue, but I think we would think more about that if you've treated with medication and we're still not getting anywhere in school, and it seems like maybe there's a learning disability there, or you question about where their IQ is, then I think psychological or psychoeducational testing will definitely be warranted. Baseline labs, just a CBC, you want to make sure they're not anemic, or CMP. We really feel like a TSH is only if it sounds like there's symptoms warrant you checking that. EEG, again, same thing if symptoms warrant, and an EKG, based upon the following questions. If you get if just one of these is a yes, then you probably need to get an EKG. If the EKG is showing you problems, then refer to pediatric cardiology. So the things you're looking for is a history of syncope or chest pain, hypertension, exercise-induced chest pain or discomfort that's not related to asthma, a family history of sudden death prior to age 30, and you want to stress with the family that this is not due to a car accident, et cetera, but it was heart-related. And then a patient or family history of congenital cardiac disorders. Now, I want to kind of explain a little bit about that. Previous slide, how this came about. So that was this controversy. In 2005, Health Canada suspended Adderall XR for about 6 months due to 20 sudden cardiac deaths, and 14 of those were kids. But methylphenidate, they weren't suspended for that reason, but methylphenidate had about 18 as well, and so 14 of those were children. So February, March of 2006, there were 2 FDA advisory panels, but they were giving us some conflicting information or recommendations. So one of them was saying, hey, it needs a black box warning with, even including stroke and MI warnings. However, the Pediatric Advisory Committee said they disagreed with them and didn't really think that the evidence was there to say that this was necessary. So in May 2006, the FDA said, okay, look, we won't do a black box warning, but we are going to recommend some product labeling changes. Then in 2008, this I will not forget, the American Heart Association said, hey, cardiologists were basically saying, we recommend that any child that's been diagnosed with ADHD undergo a screening for cardiovascular risk for initiating stimulant therapy. And some were even saying that they need to have an EKG and see a pediatric cardiologist. And I remember when I heard that on the news that morning, I said, oh, this is going to be a rough day because parents are going to be really saying, hey, I heard on the news this and my child's on a stimulant and you didn't ever, get an EKG, you never refer us. And so we had been knowing that we need to ask these other questions because of these potential problems. But even if we agreed to do this, it's no way they could handle the volume for every kid that is diagnosed with ADHD. So AAP and ACAP said, hey, this is ridiculous. And they made recommendations against such routine monitoring and basically just said, get an extensive patient and family cardiovascular history, which was just the questions that we just talked about. Okay, so if you talk about medication treatment, where do we start? And I'm not trying to insult your intelligence, just kind of adding a little bit of humor here because I have seen a little bit of everything with respect to this. So, like, do you draw names out of a hat? Because some people just say, hey, psych's not my thing. If I wanted to be a psychiatrist, I would have gone and trained in that. So, what do I do? I don't, know. And that's fine. When we tell you when you call CPAN, we see a wide variety and we want you to call. We recognize some people have limited background and some people extensive training, and we it all. Old Faithful. Some people just say, hey, look, I have 1 or 2 drugs and that's what I'm going to go by. And that's what I'm going to use pretty much in most people. So I wanted to kind of do a poll. I don't know if we'll be able to, but if you can text Lisa Falls 394 to 22333 and A, B, C, D, or E. And I just kind of wanted to know how were people approaching? Do you just kind of randomly choose, or maybe you heard a drug rep say something about it? For those of you who may still hear from those, sometimes they send it through our emails now. Or do you have a go-to drug? That's B. Maybe you look on Up to Date, and that's really a good resource for us as well. Or maybe it's parental preference. The parent comes in and says, look, I want XYZ. E, other, if you use something else. So because of time, I'm going to move through this, and if we get this back in, then we'll talk about it at the end. Okay. So factors to consider when you're talking about medications. All of these things are things you want to look at, and we'll talk about them in a little bit more detail. What medications have they been on in the past? Was it the correct dose? Family history, comorbid disorders, cost of the medication. Do you have concerns about diversion? Duration of action. Is this a young kid who doesn't have very many activities? Is this an older teenager who has tons of work, a lot of after school activities? Adherence, formulation needs, if they can't swallow pills, et cetera, side effect profile, patient preference, and then the dreaded availability, which we're all facing right now. Okay, so this slide isn't, I'm going to have a couple of these, and the take-home message for that basically is just that I can remember years ago when coming out of training, it was just a few medications, and now it's just exploded. But with all the explosion, it really isn't. I'm sorry, I'm looking in here. Go-to drug depends on age, family history, family preference. It's not a whole lot that's actually really new, if you will. It's all still kind of falling into amphetamine preps or methylphenidate preps, or then you have the non-stimulants. So you're looking at IR basically sometimes in younger kids, even though the 6-year-olds can take the extended release. If you're looking at appetite, especially for them, or sleep issues, that might be when you look at an IR. This is intermediate, 6 to 8 hours. Most people are fairly familiar with those. Some of the newer ones are going to fall under these extended release. Now, the Adderalls you're familiar with, but there's that Zenas, there's Medeas. Now, Medeas is a little different, only in the sense it's still going to be dextroamphetamine and amphetamine, but you get 16 hours. So this might be really good for teenagers who have a good appetite and a lot going on, but it's not, the FDA approval is for 13 years of age and older. Vyvanse, 10 to 12 hours. The rest of these methylphenidates, Concerta, you guys are probably fairly familiar with, but you have all these different names. Cotempla, that might be something you want to think about for people who need dissolvable tabs, or Quilichew is a chewable. We don't really do much with the Daytrana. I don't think too many people are using that. It really did produce a lot of skin irritation, and you have to pull it off if you're going swimming. And so that's a problem for kids, and then reapply, and then you need to put it on about at least 2 hours before you would want it to become effective. So we really kind of I don't see too many people using that very much. And then, of course, Focalin, Asteris is another one that's up to about 13.5 hours. It's fairly new. It's a prodrug of dexmethylphenidate or Focalin. Jornay, this particular one is delayed release. And so basically, back in the day, we had kids who, and it still is an issue, the problem is in the morning time. We're going to talk about that a little bit more a few slides down the road. But without medication in the system, because obviously when you take stimulants, it takes a little bit for it to kick in, they're disorganized, or they're very irritable, they're tearful, they're just a hot mess. And so the parents are frustrated. So we used to say, hey, if you're up before they are, give them, a small amount of medication. Then by the time they get up, you give them their full dose for the day, but that helps the morning go better. So what the makers of Jornay did is that basically you take this at about 8:30 at night so that it's delayed in its release, so it doesn't start releasing until about, 6, 7 in the morning. And the child their parent doesn't have to worry about getting up. The one thing that I haven't liked about it, so I haven't used it very much, even though the makers say that this shouldn't be a problem, some of the gurus in ADHD say it shouldn't be a problem, I still see decreased appetite. And a lot of kids, don't like that. And when it's all said and done, kind of these are basically your mechanism of actions with these drugs. I mean, basically, you're going to be dealing with reuptake inhibitors, and that's going to be methylphenidates or amphetamines, or you're going to be dealing with selective norepinephrine reuptake inhibitors. That's going to be atomoxetine or Strattera, and then viloxazine, Qelbree, which is the newest kid on the block. And one difference to note between these is that Strattera, the capsule is not supposed to be open. We'll talk about that a little bit more, but viloxazine, you actually can open the capsule. It has little beads in it. So for kids who it used to be a real struggle when I wanted a non-stimulant, such as atomoxetine, but then the kid couldn't swallow a capsule. Then, of course, your alpha-2 agonists. And then you have some release of dopamine and norepinephrine as well in the cytoplasm. So that's going to be the basic mechanism of these medications. This particular slide is basically just to kind of give you a summary slide with what you look at when you're looking at medications, and then let's say comorbidities, if it's aggression, and we're talking about comorbidity and side effect, because how you may at least do the initial treatment for a side effect that is aggression versus a comorbidity is aggression might be a little different. So alpha-2 agonists, anticonvulsants, antipsychotics, buspirone have all been helpful in terms of treating aggression and irritability when it's comorbid. And you might wonder why buspirone, but a lot of times kids who are very anxious, nervous, they don't know how to communicate those feelings, and they can become very irritable with that. And so it can help, especially if there's an underlying anxiety component. And so with anxiety, again, alpha agonists, buspirone, norepinephrine reuptake inhibitors. This is just kind of a general slide showing you this kind of thing. Tics, alpha-2 agonists are going to be helpful for that if they're already pre-existing. You might also consider, something like atomoxetine in those cases. So let's look at irritability. This was a recent trial, and this is when it's comorbid. So basically what they did, and Stephen Pliska out of San Antonio was involved in this as well, it was a stepped care randomized control of adjunctively adding in risperidone or valproic sodium or placebo after stimulant medication optimization over 8 weeks. So basically, they weren't on any meds for about 1 to 2 weeks, and then they started them on stimulants, really rigorously titrated the medication, and then basically started the step care treatment. Study participants had to have had prior stimulant therapy at moderate doses with high baseline symptom severity, and all families involved received weekly family therapy based on the community parent education program. So even if you just got stimulant therapy from the very beginning, everybody had family therapy, and it continued all the way throughout. They saw a higher than expected response rate during open stimulant optimization phase, especially for African American children. So this was kind of surprising to them for this to happen. And basically, what they realized is that truly adding in, this is what I meant earlier about driving this message home, family therapy that is evidence-based with medication, they got a whole lot, and really optimizing stimulants, they got a really bigger bang for their buck than what they had anticipated. With respect to African American children, the literature definitely tells us that they often don't get appropriate evaluation and treatment for ADHD. So because everybody was getting the same evaluation, everybody was getting a very standardized evidence-based, treatments, they think that this really kind of made up the difference there, and was a reminder that we need to make sure that we're really appropriately assessing and treating kids of color. Now, amongst the people that remitted, risperidone and valproic were both found to be efficacious as adjunctive therapy. Though we know that Depakote can cause some weight gain, Risperdal seemed to cause a lot more of it. Also, something that they found interesting is that the people who were on adjunctive therapy who remitted were still a lot more symptomatic than those who responded to just stimulant therapy and plus the family therapy alone. There were some study limitations, the short duration of the study, and then the outcomes were based mostly upon parent report, and it was limited to prepubertal females. They weren't going after that, but that's happened to be what they got, and they said if it hadn't been, they'd have been a little concerned as well, though, about divalproic in that population. And also, they don't think it could generalize to behavioral problems in kids without ADHD. So again, just a take-home message that you need to be really looking at making sure you add on therapy. This particular slide I wanted to add because I thought it was important. Stephen Stahl showed this in terms of how we evaluate treatment when we're looking at substance abuse being present. And a lot of times primary care providers don't like us in psychiatry when we say, hey, we're not going to treat and get a child's abuse be under control. So he kind of says, these are the things that should be happening first. Substance abuse treatment first. Then let's say there's mood disorders left over. Treat the mood disorder, anxiety disorder. Now he notices that, or they've noticed that usually it stops there, adults. Nobody really wants to treat adult ADHD, or some people don't even acknowledge that it exists. And so then it's done for them. However, with child, it seems to be that we skip all these steps and we really start with treating the ADHD and work our way backwards. So it really should be going in this direction to try to catch those other things first and then see what's left over. Okay, so if you're concerned about, again, we talked about this a little bit earlier, comorbidities with substance use or diversion, and you want to do stimulant therapy because maybe you're concerned about it in the parent. What are some choices that you have? You don't have to necessarily say, hey, we're going to just go with, a non-stimulant, because those, we know the literature shows us that they're not as effective as stimulants. So these are a couple of choices that you have. And why is that so? So Vyvanse is a prodrug, and basically it's supposed to be absorbed in the gut. And this particular enzymatic action, where it breaks down to lysine, L-lysine, and D-amphetamine, occurs in the bloodstream with the red blood cells. So that process is actually very slow. And therefore, even if someone tried to snort it, because usually what's giving you that high or euphoria is a very rapid type of treatment that's going on, flooding of dopamine, and that's not going to happen with this. Studies have shown it doesn't have as much likability as well because of that. Now, you do need to be mindful, because this can be kind of a slow process, that you don't want to necessarily think that giving it 30 minutes before you need it to work would be best. So you want to at least probably do an hour. Some people say hour to 2 hours. For Concerta, it basically has a drug overlay, and then underneath it's this capsule deal, and so it's the gut, and water is absorbed, this spongy kind of layer that starts expanding. That's how you push the medication out that little hole, and you get your sustained release. But the company, if someone tries to crush this, supposedly this just null and void, it doesn't work. Sure, they would get a little bit of that drug overcoat, but they wouldn't be able to use the medication inside. So it used to be, when we were first kind of starting this out, it's kind of shocking being a childhood, a thought to be mostly childhood disorder, that we didn't have a lot more things, considering children usually can't swallow pills or capsules. So now I've really changed my previous slide, because basically they have tons of options now. So I really kind of tell people now, focus on now what you shouldn't open. We just talked about Concerta, so you don't want to do that one in terms of if a child can't swallow a pill or a capsule. And then atomoxetine. Again, the drug company, basically, I had a kid that just insisted on opening the capsule, and the mom was concerned about that, since me and the pharmacist had told her not to open it. So I called them and said, okay, is there any harm in this? And they basically said, no, it's just very caustic to the stomach. And so that's why we don't say you can open the capsule and it tastes horrible, but this kid didn't have a problem with it. So for that reason, you don't want to open that capsule. We talked about morning. Intuniv and Jornay, we've already talked about Jornay. With respect to Intuniv, or extended release guanfacine, I like to give it in the morning. Some people like to give it at bedtime. Initially, they told us it was, oh, you just give it once a day. And we've really kind of found that a lot of times people are going to need this more than once a day. But for those kids who really have rough mornings, if you give it at bedtime, it help with that. Not lasting long enough, you want to consider an XR if they're already on an IR. Also be mindful that some kids have a really long day. Even if they're really young, they may have to get on the bus at 6 or 7 in the morning and may not get home till 4 or 5 in the afternoon. So even if they're on an extended release, they still may end up needing another dose later in the day, like around 1 or 2 o'clock. You can also increase the dose. It doesn't give you a lot of time, like hours, but it may give you an hour-ish to get a little bit edit on if you don't want to have to add on a second dose. But then sometimes you're just going to have to add those multiple doses still, even with the extended release. Where did all the stimulants go? We're all wondering that, and it's been a pain having to deal with this. So it's been thrown around out there that demand is higher. Basically, more people are being diagnosed, number of prescriptions have gone up, and then the manufacturers are saying that the federal government isn't producing enough or releasing enough of the stimulant medication to make more. The federal government is saying they're releasing enough, and they're not going to change that. So they kind of just say it's a manufacturing delay. Then on top of that, when the pandemic occurred, there's been now thought to be somewhat of a workforce shortage. So all of these things are supposedly what's contributing to the problems with finding medication. And I can honestly say this is a Band-Aid. I think it's going to have to be something that happens with the government releasing more. But in the meantime, you can have parents check pharmacies and, say, hey, can y'all please hold this amount for me? My provider's going to be sending some right away, because it has been a nightmare. You send it and then they call back and say the pharmacy says no, and then you have to send it somewhere else. Consider a generic or maybe an alternate brand name medication that's still within the same class if that medication has been effective. Or, if they're kind of doing okay, it might be a time, but they're having a few problems still, it might be a time to switch to maybe the other class. Consider a slight dosage change. If they're still having a few problems, you might want to consider going up a pinch on the medication. Or if, they're doing okay and they've done okay for a while, you might look at going down a little bit, or especially if they're having side effects. Check with your institution. UTMB sent out an email to us not too long ago that they are going to be having it at their pharmacy, ordering enough, but really just for UTMB patients. So maybe your institution has the ability to do that. I would also consider avoiding writing large quantities, even though families often will ask you to do that. Look, we don't want to go through this. Can you send us a 90-day supply? Some insurances will cover that. But I think it really does just add to the shortage problem. Alternative treatments, we won't spend a lot of time on this, as I see that the time is winding down, but basically sometimes you'll have parents that come in and they're going to ask you about this. And, this is the numbering is 0 to 6, with, 6 being the best. Some people talk about like restrictive diets, food sensitivity, but there are problems with it. Sometimes nuisance, expense, and nutritional balance, sugar elimination. Although everybody's convinced, like all kids get a little hyped up with sugar, let's face it. But in terms of really eliminating sugar from the diet, there's not been anything that says it, that's helpful, and it may actually delay standard treatment. I think iron supplementation is a cofactor for catecholamine creation. So something to think about. They're needing more controlled studies though, and you can get hemochromatosis from excess. Zinc supplementation, again, needing better trials in that 3B. Magnesium is 3B. You can get some aggression from excess with that. And then comprehensive supplementation, it can be expensive, can be a nuisance, but it's a 3 right now, and needing replication studies. All right, so side effects, appetite suppression. We kind of, I think sometimes just blow by this for kids, and kids like to eat. We like to eat in a society, and so that can bring us pressure. Things that they normally like to eat, it makes them sad that they can't eat it. So it is something we need to take seriously. You can look at decreasing the dose as kind of a first thing to look at, or maybe make sure they're given after a meal. The parent will think, because they're maybe, giving it real quick and making sure that they eat at school, they think that they're addressing this. But sometimes when they try to do that, depending on where they go to school or how far that is from home, it can cut their appetite before they even get to school. So sometimes your option is to then have the nurse give that dose after breakfast in the morning, or you can tell them to get a Hot Pocket or whatever. It's not the healthiest thing, but it does get some food in their stomach before they take the medication. Changing to IR if they're on XR, especially if they're younger kids, taking that second dose after they eat lunch may give them a little bit of time for them to get food in, because usually it just cuts their appetite during the day and they don't eat lunch. If a child has maybe comorbid depression, anxiety with insomnia, and a decreased appetite, this might be something to consider is mirtazapine. It's off-label even for treating depression in kids, but we do use it, and it can be very effective in these kinds of situations. Perheptidine, if kids are having allergy, we'll tell them to get off of their other allergy medication and maybe consider doing this, but we tell them to talk to whoever's, if they're having something prescribed for them, talk to them first. And again, this is off-label, but it can be very effective in boosting appetite. If this child has been tried on everything else, you've made changes, nothing is seeming to work, and they're doing really well on a particular medication, and you just want to boost the appetite, sometimes this is where we go. Insomnia, ACAP practice parameters talk about melatonin, clonidine, trazodone, and histamines. Be mindful with melatonin. Parents will say, oh, it's natural. And they think that means you can just give as much of it as you want. I've had parents say they gave 30 milligrams to their kids. And so you want to give them some kind of guidelines on that. I'll give you guys some guidelines. It's a link at the end that covers all sorts of medications, but they kind of recommend no more than 6 milligrams of melatonin for kids. Clonidine, again, usually the IR is going to be more helpful in sedating if kids are just having initial insomnia. If people kind of need that, they're having problems sleeping even throughout the night, then you could consider CAPVA, the extended release Clonidine. Trazodone, be mindful of. Priapism, even though it is rare, you do need to tell them about that. Next day sedation can be a problem, and as well as serotonin syndrome, but it can be very helpful for sleep. Antihistamines, especially if a child has allergy stuff, but remember, you can get a paradoxical response with that. These are just some key medication points that I like to drive home, because I see this being a problem sometimes when medication is not effective and they say they're on Strattera and it didn't do anything, or any of the alpha-2 agonists. So Strattera or atomoxetine must be taken daily. And if you know that, you may know that, but the parent may not know that. And if you don't stress with them, it must be taken daily. They often think, oh, all ADHD medication is the same. So they'll just give it on school days. You need to stress giving it every single day. With respect to dosing, some people treat it like stimulants and, I'll just start them at 18 milligrams. This is a weight-dependent medication, so it needs to be really 0.5 mg per kg. And then after 4 days, you go straight to the target dose of 1.2 milligrams per kilogram. FDA max is about 1.4 mg per kg, or 100 milligrams, whichever is the least. And then off-label max is 1.8 mg per kg, or 100 milligrams, whichever is the least. Alpha-2 agonists, same thing on making sure that they take it every day. It's Strattera or atomoxetine was originally developed to be an antidepressant. It wasn't very effective for that, but good for ADHD. So it's going to kind of function like an antidepressant. 4 to 6 weeks before you see the full effect, but you usually see something in about 2 to 3 weeks. Alpha-2 agonists, about 1 to 2 weeks before you see the effect on that. This was just a study done on lisdexamfetamine, and basically this was addressing some of the things that were seen in the MTA study, but this was a little bit more recent. And the greatest delays seen were for heaviest and tallest children, and those without prior exposure, and with the longest cumulative exposure, 13% decrease in height. So we do need to be mindful of this. If you start seeing a kid starting to level off, you need to address that. So MTA, when I was speaking about that, again, this is going to drive the point we talked about earlier, where combination treatment and medication management alone basically were both found to be significantly superior to intensive behavior treatment alone, or to just routine care in reducing ADHD. And these benefits seem to last as long as 14 months. Other areas of functioning, anxiety, academic performance, combination treatment, again, was consistently superior to routine care, whereas medication alone or behavior treatment alone were not. In combination treatment also, they don't need as high of doses of medication as kids that were in the medication alone group. And this was seen across all 6 research sites, despite differences in the children's socio-demographic characteristics. And then they addressed safety as well. Of the 289 children that were randomized to medication, 4% had adverse side effects that caused them to stop taking the medication. Those things were things like decreased appetite, sleep problems, crying spell, tics, repetitive movements. And on those meds, if you were on them daily, it was a 2 centimeter change in height, as well as 3 kilograms less than those who were just on behavioral therapy alone. So you do need to let parents know that there may be an issue with height. And then that side effect or those growth effects may persist even if, if you're going to continue the medication long term. What they kind of found in that study as well is that holding it on the weekends didn't really seem to help. The verdict was still out about holding it like over long holidays like the summer. I personally, when I would hold medications over the summer, a lot of my kiddos caught up, but anything kind of under that, those little short breaks didn't seem to help. 8% of the children, however, were successfully treated for the full duration of the study. I put this in here because sometimes, again, we can forget this part of it, because some of you might be thinking by now, like, who has time for all of this? We don't have time for this. With getting histories and things like that, that's where you might want to utilize medical students if you have them. If you're talking about some of the other things, maybe if you have a social worker available, they can help you with things like this education support or getting referrals for behavioral therapy. So this is the American with Disabilities Act and Section 4. So you'll hear schools talk about 504 planning or 504 accommodations. It's really important that you advocate for your child, that you're treating, or help the parent advocate for them. So basically, that act just prohibited denial of educational services and discrimination against students with disabilities. It allows the parent to request an evaluation if they suspect a disability in their child. However, when you're telling them to do that, make sure you tell them to put it in writing. If it's not in writing, most of the time the school is not going to acknowledge it. 504 accommodations are basically going to be classroom changes that help the child in meeting requirements, but without actually lowering the academic standards. But then you have IDEA, or Individual with Disabilities Education Act, and this basically guaranteed free education, public education for students with disabilities, and it required those kids require specialized instruction in the least restrictive setting. It's a lot more comprehensive than your typical 504 plan. ADHD as a diagnosis qualifies under that, under the other health impaired or OHI. They'll often have you fill out a form that say that they have ADHD and it's just real quick, how that's going to impact their classroom performance. A parent can request an independent evaluation if they disagree with what the school psychologist has said or school has evaluated, but the school is not bound by such outside recommendations. And I've had schools used to tell me that, remind me of that, I should say. And then individual education plan. This basic, or IEP, you'll hear it kind of abbreviated. This is for modifications, and it's depending upon the disability, but it's where the student wouldn't have to actually meet the equivalent academic standard as what you would have in regular education. Okay, so the medication's not working. What do you do? We've talked about a lot of different things. You're going to look at dosing, adherence, adherence, adherence. I would say this is probably one of the main reasons why most kids don't do well, more so with other disorders than ADHD, but it can even be the case in ADHD, because remember the times of ADHD, getting to patients. DACON, that's daily average consumption value. And basically, to put it simple, it's just kind of saying how many pills did they really take versus how many you actually prescribe them. How often are they being persistent with the prescription refills? So are they requesting those refills on time? And if you know that there might be some variation, because especially if they're stimulants, they might not be taking them on the weekends. But if in the like atomoxetine or those type of medications, you definitely need to be looking more. Now, sometimes it's hard for you guys because if you give them a bunch of refills, you won't be able to really tell that they're not taking it. And I would venture to say that almost the majority of my patients have issues with being compliant enough to where the medication will work. Are you needing augmentation more than, trying to do all these sorts of things and nothing seeming to work? Think about adherence. Consider adjunctive treatment with alpha-2 agonists if you feel like they are being adherent and the stimulants aren't working, or maybe you're having to kind of back down on the dose for side effects. Combined can be very helpful. And then let's not forget reevaluating the diagnosis. We have to do the same thing in psychiatry because sometimes we think, we got it, we didn't really get it right, and it might really be bipolar. It might really be something else that we missed. In summary, this is a summary of American Academy of Pediatric, their kind of way of evaluating this, and I thought it was really good, so I included it in here. But basically, an evaluation for ADHD should be initiated in any child 4 to 18 who presents with, academic problems and ADHD symptoms. Making a diagnosis, of course, back then when they were, this was DSM-4, now you're talking about DSM-5 TR, have been met, including documentation of impairment in one or more setting. Sometimes I definitely see that where they're really meeting the criteria, but we're not very good at documenting that they've met the criteria, or that they are having problems in more than one setting. And then a primary care clinician should rule out an alternative cause. And evaluating a child for ADHD include assessment of other conditions, as we've talked about earlier, that may coexist with ADHD. Recognize ADHD as a condition that is chronic, and children and adolescents with ADHD as children and youth with special healthcare needs. Recommendations for treatment are going to really vary depending on age. So in preschoolers, age 4 to 5, behavioral therapy is first line. A is for, basically standing for well-designed controlled trials or diagnostic studies or relevant positions, and A is going to be a strong recommendation. Methylphenidate if behavioral therapy fails, and that's going to be B, meaning that, it's strong to just regular recommendations. And then keeping in mind that atomoxetine, guanfacine XR, clonidine XR are not FDA approved in this age group. And actually, none of the extended release stimulants are either. And even though this says methylphenidate if behavior therapy fails, honestly, under age 6, it's generally just Adderall or the mixed amphetamine salts and Dextrogen that are FDA approved. But sometimes they can just really cut appetite, and I kind of really like methylphenidate better in this group as well. Elementary school age children, 6 to 11, FDA-approved medications for the treatment of ADHD, again, are going to be first line. That's an A recommendation. Behavioral therapy will now be B. And again, same thing that we kind of talked about above, but evidence is strongest for stimulants, less strong for atomoxetine, guanfacine. Basically, any non-stimulant is not going to be as effective as a stimulant. Adolescents age 12 to 18, FDA-approved medications in the treatment of ADHD are first line, A. Now behavioral therapy kind of drops to a C. And again, they're saying the same thing about evidence is better for stimulants than non-stimulant therapy. You want to titrate doses of medication to achieve the maximum benefit without or with the minimum adverse side effects. This particular resource guide, I don't know if CPAN will be super happy with me, but I feel like it's best to kind of help you guys than to necessarily, think about CPAN first. That is a link that would take you to a guide, not just for ADHD medications. It's going to be everything we treat, including side effects, including cross titration methods. It covers antidepressants, what's FDA approved, what's not FDA approved, what are the FDA maxes, what's off-label maxes, because I know that you guys probably feel a lot more uncomfortable when you're having, we talk about off-label maxes. This gives you something that you can say, hey, justification for doing that sort of thing if you feel comfortable with that. It covers, all of the atypical antipsychotics and what they're used for. So it's just very comprehensive. And if it's something you're interested in, please, by all means, take a look at it. With that, I'll wrap things up and we'll take some questions. Sorry that this went on a little bit.
That was great information, Dr. Falls. Thank you so much for presenting today. If you have interest in asking questions, you can either place those in the chat, or you can go ahead and unmute yourself if you're interested in asking the question directly. We do have a few minutes still here available. So I'm going to open it up to the floor. And again, it's fine to go ahead and unmute yourself if you'd like to ask Dr. Falls a question. While we wait for questions, one of the things that I have heard our psychiatrists talk about to Dr. Falls is that trauma is one of those things that can mask itself as ADHD. And I think it's one of those areas that it appears that primary care providers, both family medicine and pediatricians, still aren't always assessing for in their children. Can you speak to that as well?
Yes, and for us, that's why doing an eval, and I think the reason why you guys don't assess for it is not that you don't want to. God bless you guys. I think just the fact that you all can get done what you do get done in such a short period of time is nothing short of amazing. For sure, on the first visits, we ask everyone about any history of physical or sexual abuse that they maybe, have experienced. I taught for a year. I was determined I was going to not go to medical school without a car after I did undergrad without one. And so I was in a low income school, and quite a few of my kids had abuse, and just had no idea like the impact that it was having. These kids they don't get the luxury of thinking about homework or what you're talking to them about in school right then. They're sitting there, they're thinking about the beating they just got the night before, how they're going to avoid the beating when they get home, or that they don't have any food, or whatever the case may be. So it definitely can look like ADHD when in fact it really isn't. But you need to let kids know even at the beginning when you ask, because you may not have time to ask every visit, but just remind them, say, hey, you may not have this problem now, but down the road, if anybody touches you, anybody, whatever, go over those things with them. Please, I'm a resource. I want you to feel like you can come to me and talk to me and let me know.
Great. Thank you, Dr. Falls. I am showing some slides, so if you have a question, I am sorry that I cannot get to the chat at the same time as showing slides here. So please feel free to unmute yourself and ask those questions.
I don't see any. In terms of.
All right, if there are no questions, I am going to remind you, if you were seeing the slides earlier, and some of you came on after the disclosure slides, I am going to move to the slide for our future sessions. We do have Project Echo that is occurring right now. Both the UTMB team out of Galveston and our team here in Tyler are providing sessions for Echo. I have the Echo sessions for our team here in Tyler. They are every other Friday, and you register for those. The UTMB team does have their own on their different dates and times. You would need to contact your CPAN team at UTMB to register for that, and registration is required for Echo. Our next CME session is scheduled for the 18th of May. That is an ethics credit session on recognizing and reporting child abuse. That session will not be recorded. We record typically all of our sessions, but because of the sensitive nature, of that session, we are not recording that. Right now, we have been working with the team that presented last year. It was a panel. It'll be a panel again this next year, which will include Megan Richardson, one of the forensic nurses at our local ER, as well as the local Smith County District Attorney is supposed to be a part of that as well. Tyler Police Department, Child Investigations, and the Child Advocacy Council. So there will be a panel for this. It is expected to provide you ethics credit. It will be from 12 to 1 on the 18th of May. We hope you can make that session, not just because it's an ethics credit, but because this is an extremely important topic that we all need to be refreshed on at least annually. Dr. Falls, I want to thank you again for presenting again for us here today. I want to thank our partners at UTMB in Galveston for being excellent partners in our continuing education for 2023. I hope that those of you who have attended today will join us again in the future for sessions, and we hope you have a wonderful day. Thanks now.